Hi friends, in this series of ECG basics, today I will talk about right ventricular infarction and the ECG changes in right ventricular infarction. First is the disclaimer. Caring Jokes YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. We should always suspect and look for right ventricular infarction in all patients with inferior wall ST elevation MI. The diagnostic ECG criteria is in patients with inferior ST elevation MI, right ventricular infarction is suggested by ST elevation in V1, ST elevation in V1 and ST depression in V2. This is highly specific for right ventricular infarction. Isoelectric ST segment in V1 with marked ST depression in V2, ST elevation in lead 3 more than lead 2. Diagnosis is confirmed by presence of ST elevation in the right-sided leads, that is V3R to V6R. V1 is the only standard ECG lead that looks directly at the right ventricle. Lead 3 is more rightward facing than lead 2 and hence more sensitive to the injury or current produced by the right ventricle. The clinical significance of the right ventricular infarction. The right ventricular infarction complicates up to 40% of the inferior ST elevation MI. Isolated right ventricular infarction is extremely uncommon. These patients are preload sensitive due to poor right ventricular contractility and can develop severe hypotension in response to nitrates or other preload-reducing agents. Hypotension in right ventricular infarction is treated with fluid loading and nitrates are contraindicated. The ECG changes in the right ventricular infarction are subtle and easily missed. Coming to the pathophysiology of the right ventricular myocardial infarction, it typically results from acute coronary syndrome involving the right coronary artery. The proximal lesion may involve the right atrial branch with the loss of augmented right atrial contraction and may result from systemic hypotension also. The so-called right ventricular infarction often does not progress to Q-wave infarction because of greater resistance to ischemia than the left ventricle. Pulmonary circulation is approximately one-tenth the length of the systemic circulation and a 5 mm of mercury perfusion gradient is sufficient. The thin right ventricular free wall allows the biphasic perfusion of the coronary blood with approximately equal contribution during the systole and diastole. The right ventricle has rich collaterals from the left anterior descending artery in addition to the right coronary artery blood flow. So it may be mimicked by a stunned or hibernating right ventricle. The patients with right ventricular myocardial infarction, they present with ischemic chest pain, bradycardia, hypotension, they have clear lungs, they may have distended neck veins and Kussmaul sign, that is Kussmaul type of breathing. The complications are ventricular septal rupture, hypoxemia from right to left shunting, hypotension from the ventricular interdependence, high grade AV block, vagal nerve mediated bradycardia, and ventricular tachycardia. Whenever the patient's presents with RVMI, ECG may be ECG findings may be transient and usually 50% of the cases they resolve within 10 hours. ST elevation in V1, the only standard ECG that looks directly at the right ventricle. ST elevation in lead 3 more than lead 2 because lead 3 is more rightward facing than the lead 2 and hence more sensitive to injury current produced by the right ventricle. ST elevation in V1 more than the magnitude of ST elevation in V2. Combination of ST elevation in V1 and ST depression in V2 is highly specific for a right ventricular myocardial infarction. ST segment in V1 is isoelectric and the ST segment in V2 is markedly depressed. It is confirmed by ST elevation in right-sided chest leads, that is V3 to V6R, and V4R is usually the sufficient because ST elevation in V4 has a sensitivity of 88% and specificity of 78% and diagnostic accuracy is 83%. In laboratory, we can do drop eye. Echocardiography will show the evidence of right ventricular dysfunction, regional wall abnormalities, and exclude the other cause. Technically challenging as right ventricle cannot be completely visualized in any single 2D view. Other investigations which we can do are cardiac MRI and 3D echo. These are the emerging modalities. Coming to right-sided leads, a complete set of right-sided lead is obtained by placing leads V1 to V6 in a mirror image position on the right side of the chest. It may be simpler to leave V1 and V2 in their visual or usual position and just transfer lead V3 to V6 to the right side of the chest, that is V3R to V6R. The most useful lead is the V4R, which is obtained by placing the V4 electrode in the fifth right intercostal space in the midclavicular line. The ST elevation in V4R has a sensitivity of 88%, specificity of 78%, and diagnostic accuracy is 83% in diagnosing right ventricular myocardial infarction. The ST elevation in right-sided leads is a transient phenomena. It lasts less than 10 hours and in 50% of the patients with right ventricular infarction. This ECG shows inferior ST elevation MI. The right ventricular infarction here is suggested by ST elevation in V1, ST elevation in lead 3 more than lead 2. Repeat ECG of the same person below shows V4 electrode in position. There is ST elevation in V4 consistent with the RV infarction. In this ECG, we can see a full set of right-sided leads, that is V3 to V6R, with V1 and V2 in the original position. Right ventricular infarction, it is suggested by there an inferior ST elevation MI with ST elevation in lead 3 more than lead 2. V1 is isoelectric while V2 is slightly depressed, and there is ST elevation throughout the right-sided chest leads. Dr. Henry Knowles has said that the best cure for the body is a quiet mind. With this, I conclude my today's topic. Thank you. Keep learning.